So good morning to everybody. Today I have a challenging topic, that means the choosing of stent and antiplatelet therapy in high bleeding risk patients. We know that there are some factors associated with an increased bleeding risk after PCI, and you can see the age, renal disease, liver disease, active cancer, something related to laboratory testing, bleeding history, iatrogenic as well. And we have also factor associated with an increased ischemic event risk after PCI, like prior stent thrombosis or adequate antiplatelet therapy, stenting of the last remaining patent vessel, diffuse multivessel disease, kidney chronic disease, extensive stenting, and bifurcation, as well as total occlusion with long stents that mean more than 60 millimeters. And depth intensity and duration is related to patient, related to lesion procedure, related to stent as well. And the patient comorbidities, demographics, comorbidities, and clinical manifestation, with whether it is acute coronary syndrome or chronic, coronary lesion characteristic, procedure factors, stents, and so on, should be carefully evaluated in order to balance bleeding against ischemic events with the depth. And this is particularly important in high-risk bleeding patients. Of course, the first thing to do is to minimize the risk of stent failure. And we have spoken yesterday, the keys of success is keep it as simple as possible. Don't do bulky things particularly on the carinae bifurcation. Step-wise approach, even with the simple stenting. Intravascular guidance is recommended always, and lesion preparation, stenting, optimization, that means well expansion, good apposition of the stent is absolutely important. We have, in order to evaluate the risk of bleeding, we have several score systems coming from trials mainly, and the most used and recognized by guidelines is precise depth score as well as depth score, and this is show you how the risk is endorsed by guidelines is useful in for predicting bleeding events in patients with acute coronary syndromes undergoing angioplasty, as you can see in this study. Now, I'll start with a clinical case. This is a clinical history of this patient, 84 years old, type D diabetes, anemia, moderate chronic renal insufficiency, peripheral artery disease, and previous gastric ulcer, bleeding healed 8 years ago, previous inferior myocardial infarction, and then evolved in ischemic left ventricular dysfunction. Now he has ejection fraction of 0.45. In May, he was admitted for chest pain, ST depression in anterior lead, posterior akinesia, anterior hypokinesia, and ejection fraction was 0.35. T-troponin increase, persistent discomfort. And the strategy, of course, in this patient is very challenging because he is a very high bleeding risk patient. So PCI is complex with severe calcification, severe distal left main lesion, and I'll show you, this is the angio. See heavily calcified left main and almost all the proximal and mid segment of LAD and diffuse disease. And of course, in this case, I think the principal thing to do is to prepare the lesion as much as possible in order to be sure that your stent will be fully expanded and fully apposed. And of course, in this situation, I think debulking by rotablation, at least by rotablation, is absolutely necessary, as well as IVUS guidance in order to reach after your procedure, to reach the most optimal result in this patient. And you can see very, very good final result with fully expanded stents and in left main and LAD, as well as distal left main bifurcation. Then optimization should be done, and this is the final result. Now, this going for the clinical data, what we have about the depth in these patients, we have here the meta-analysis coming from 5 randomized trials, and you can see that mostly at least 50% of cases included in this trial with acute coronary syndromes. Mean stent length is almost long, because ranging between 25 and 40. And I would underline that variety of stents have been used in all these trials. And if you look on the outcome, you can see that there is no difference in ischemic events and shortening the depth duration. But what the most benefit is less bleeding events in these 5 randomized trials. Then more recent trials like Master Depth trial, showing again that this was with Ultimaster stent, again that clinical events, adverse clinical events are not changed, shortening the depth for 3 months, abbreviated that at 3 months, and what will have the benefit, the most important benefit, that we are reducing significantly bleeding in this cohort of patients. Again, from Science 90 and Science 28 studies, showing that, again, no difference in clinical events, but bleeding, major bleeding, I would say, are significantly, markedly reduced, reducing the duration of depth from 6 to 3 months. And if we look also further data from the same studies, Science 28 and 90, coming to only one month, this will have the same outcome. That means reducing ischemic events, reducing bleeding events without any change in ischemic events. The Evolve short depth study done with the Synergy stent, again, one of the stents mostly used today in our clinical practice, and showing again no difference between in clinical outcome, that death and myocardial infarction in between 3 and 15 months, while the stent-related ST signal, that means stent thrombosis, is not changed, and the bleeding events are reduced. Now, again, this is another very recent study showing that the de-escalation and short dual antiplatelet therapy, there is no difference in the 2 modes of abbreviating the depth, no difference. The only difference that with the short depth will reduce bleeding events more than the de-escalation, while de-escalation might slightly reduce clinical events as compared to short depth. Which stent? Here is 2 editorial by Capodanno analyzing all the studies done with short depth, and this show that most of contemporary stents were included in this study, and all of these study was showing that reducing the duration of depth will reduce bleeding, but will not affect the efficacy in all, whatever stent we are using will be the same result. Now, again, this coming from how to do it. I mean, to summarize what is coming from trials, again, starting from clinical judgment, then the first step is risk classification, which then depends on complexity of the procedure, the risk scores, genetic testing, and platelet function testing sometimes are required and could be done. After this, patient will be classified as high bleeding risk, low bleeding risk, and low bleeding with high ischemic risk, as well as low bleeding risk with low ischemic risk. In this category, that means the middle one, this is the most simple, why we can keep the standard duration. That means at least 6 to 9 months in depth, while in the other, that means in this side, that high bleeding risk with regardless of ischemic event should be shortened, and this will not affect, will reduce the bleeding, but without affecting the outcome. Again, the shortening the antithrombotic therapy will, this is show globally that will reduce a bleeding event and will not affect the outcome of the procedure in terms of ischemic events. This is in acute coronary syndromes, as well as in chronic coronary syndromes, the same result will be obtained. The only difference that in acute coronary syndromes, if it is the bleeding risk is low, then duration of depth should be extended to 12 months. And the most used scores are precise depth score and depth score. And you see here that these with the simple, easy, and rapidly available can give you the possibility to classify, to locate the patient, and to do your procedure and the depth after accordingly. This is coming from the most recent guidelines of American Society of Cardiology. And I would say that respecting what we have seen from the trials I mentioned before, and this is the summary of guidelines that mean including American College of Cardiology, American Heart Association, and the European Society of Cardiology in stable and chronic ischemia. Then there is no high bleeding risk, no any change. That means 6-month duration should be kept, while in high bleeding risk, this can be shortened safely. We have more support by European guidelines for 1 month rather than the American College of American Heart Association, American College of Cardiology guidelines. And in acute coronary syndromes, you can see that in no high risk for bleeding should be maintained, the depth maintained until 12 months. Some is suggesting to even prolong to 30 months, but this is not well supported by clinical data. In high bleeding risk, again, the shortening, but we still not in class 1A. Now, my take-home message is that in high bleeding risk patients, procedural optimization is the first step to reduce ischemic events and to predispose for a short depth. Evolution of stent technology plays an important role in shortening depth duration. Short depth duration, 1 to 3 months, have been proven to be effective in reduction of major bleeding without an increase in ischemic events as compared to long depth. And almost all contemporary stents used in daily clinical practice can be safely used with short depth. Thank you very much for your attention.